Okay, I think it's time to start, and you're all ready on the Institute side?
Great, okay. Welcome to the third live session. As you know, since we launched this course back in April, we had two live sessions as part of the course Leveraging Primary Healthcare for the COVID-19 response. The first live session was, as you remember, it was about the experience session on global and Ethiopian primary health care system, particularly the health extension program. And we had invited guests from the Ministry of Health and also from Johns Hopkins University. And we also had the second one, which was adaptation of COVID-19 guidelines, implementation for PHC focus and attainment of universal health coverage. Now we are having the third live session as part of the course, which is entitled Frontline Health Workers, Service Delivery and Innovation for the COVID-19 Response and the Country Experiences. We have guests from AMREF who will be introducing later the speakers. With us, we have Dr. Maika Schleif, who will be introducing the speaker. She is from Johns Hopkins University, and she's a scientist and working at the International Health Department at the Johns Hopkins University. And with me, we have a global PhD support team, Bru and Tersit. So with this, I would invite Bru and Tersit, Dr. Maika Schleif to introduce the speakers, and we'll go from there. Thank you and welcome, welcome again.
So thank you, Dr. Antara. I just want to say all participants, thank you for your interest in our course and moving with us in all our progresses. We will be updating you in our weekly update emails, but now I wanted to recommend you to finish all the contents in the platform and get your certificate of completion, which will be automatically generated from our learning management platform. So I highly appreciate if you can complete all the contents in the platform in the coming 2 weeks. Still, you can invite your friends to this course, because all the contents are now available in the platform, and the recordings of these live sessions are also embedded within the topics or the modules which are supported by those live sessions, so they can have a quick progress with the course and get their certificate of completion in the coming 2 to 3 weeks. So I want to say thanks once again.
Thank you, Bru. You, Maika, to introduce yourself as well as the speakers.
All right, great. Thank you, Dr. Antana. Thank you, Bru. It's very exciting to be with you all for this final live session for the course. It's been a real pleasure to get to know so many of the attendees and to have some really lively and insightful conversations with the experts that we've had join these sessions. So today we have 2 colleagues joining us from AMREF. The first one is Peter Otino. He is the Operations and Delivery Lead at AMREF Enterprises, and he's based in Nairobi, Kenya. He has a Master's of Science in IT from the London Metropolitan University, and he's bringing extensive experience with e-health and technological solutions and services to support program implementation. So we're very, very excited to have Peter joining us and sharing some more about the work that AMREF has been doing and that he's been leading and working on. And our second speaker is Sintayo Abebe. He is the Reproductive Maternal Newborn Child and Adolescent Health Program Manager for AMREF based in Addis Ababa, Ethiopia. And he has a Master of Science in Global Health and Development from the Hanyang University in South Korea. And his work really focuses around the design, implementation, and monitoring of maternal, child, reproductive, adolescent health programs. And he's worked a lot on adolescent and youth health strategy and programs as well. So we are very, very excited to have both of these colleagues joining us. They'll be sharing a presentation first, and then I'm very excited to be able to ask them some questions and delve more into the work that they've been doing, how they've been supporting the COVID response, and hear a little bit more about service delivery, frontline health workers, and some of the support that AMREF and other partners have been providing. So welcome to you, Peter and Sintayo. And I've stopped sharing my screen, so if you all want to share your presentation, when I hand over to you with a warm welcome, please feel free to introduce yourselves as well and take it away.
Thank you. I think I'm having some challenges sharing my presentation. I had shared it. I don't know whether you're able to share it from that side or.
Sure. I've made you co-host, so I'm happy to share it from this side, but you should be able to now as well, if that's easier for you.
Just a moment. I'm still having an issue.
Okay, I can share from this side and just
Thanks.
let me know how you want to, when you want to move on, and we'll do it that way.
Okay.
All right,
Just
go
move
ahead.
to the next slide, please. Yeah, so I think, thank you everyone, and thank you for joining this session. So one of the things about our platform is that we've realized that there are issues with health systems in the wider sub-Saharan Africa. And these issues are related to communities having limited access to healthcare, and also community health workers who support these communities having limited knowledge on preventive and curative measures that need to be put in place. But one of the things that we also realized is that with the onset of the pandemic, traditional methods are simply not enough. What we are saying is that traditional training methods are not COVID resistant like everything else. And here, what we are saying is that there's the aspect of they are not able to provide real-time information, they are not able to provide centralized databases, and they're not able to provide opportunities for distribution of information in a timely manner. So what we've done is that we came up with a platform which we have been implementing for quite a while in different countries in sub-Saharan Africa. And the platform is called LEAP. Mike, maybe we can go to the next slide. So if you look at LEAP, it's a training platform that delivers content via very basic phones. And we are able to leverage on different functionalities through the platform. We have evaluations through quizzes and assessments. We have collaboration through a group chat functionality, which works a lot like WhatsApp. And we're able to have a centralized database of community health workers. What this helps ministries of health, development organizations, and different partners with is that you're able to establish what the real training gaps are with particular community health workers or health extension workers in the Ethiopian context, and be able to put interventions that enables them to have the requisite knowledge to disseminate to the communities that they serve. Possibly could go to the next slide, Mickey. Now, if you look at our scaling path, quite naturally, one of the things that happens is that we establish a baseline, and the baselines enables us to understand what the context-specific solution is. Once we've established a baseline, what we normally do is create a feasibility study, and the feasibility study enables us to understand what are the key success criteria that we need to put into place in order to successfully implement the solution within a particular country. Then what we do is integrate the solution within existing Ministry of Health frameworks. One thing about the platform is that it does not exist within a silo. It's not a vertical solution, but a horizontal solution that fits within a wider framework that exists within the MOH and national government frameworks. And through this, we are able to scale by adoption of people within the private sector, people within development organizations, or even the Ministry of Health. And now this enables us incorporate different business or scalability models. Possibly could go to the next slide, please. So if you look at some of the key challenges currently being addressed by the platform, from a government perspective, one of the issues that is there is limited budgets available to the government. Then governments do not also have a centralized database of community health workers or health extension workers in the context of Ethiopia. And you also find that different development organizations have a siloed approach in the way interventions are disseminated within the wider countries that we operate in sub-Saharan Africa. From the CHW perspective, there's limited knowledge on health. Training is fragmented. You find that most countries in Africa do not have a harmonized curriculum to roll out CHW training. There's also an aspect of what is formal education. Are we talking about primary school education? Are we talking about secondary school education? And there's no key criteria that determines what the basic education should be. Then there's also issues around internet. Most people do not access internet. So how do we provide education using basic infrastructure where telco organizations are concerned? Then if you look at the communities, there's limited access to knowledge about common preventable diseases. There are issues with referrals, and definitely most people do not have health insurance and tend to have out-of-pocket payment whenever they experience a health issue. Next slide, please. So if you look at this in totality, one of the things that comes into mind are what are some of the preconditions for success within different countries in sub-Saharan Africa. So if you look at the health system as an organization, one of the things that we've done is that we've tried to position ourselves to structurally change training of community health workers. This is through advocacy efforts when we partner with the Ministry of Health, and even trying to ensure that community health workers are paid for the work that they do. If you look at the aspect of health education, there is no dominant learning solution within the wider sub-Saharan Africa. However, there are opportunities for different players to come together with different skill sets to be able to create a solution that is adoptable and scalable within the wider sub-Saharan Africa. Then if you look at the aspect of community health workers, how do we ensure that we are able to provide them with formal training using a harmonized curriculum, and are there opportunities to create a career pathway for respect of the technological setup? How are we able to, in an agile manner, create quick turnaround solutions based on responses to epidemics, pandemics, without relying on mobile network operators, and looking at global players who can quickly roll out solutions. Then in terms of organizational context, how do we provide in-country staff with the requisite skills to provide support to the Ministry of Health, to community health workers, and also to be able to provide scalable skills to the wider players and partners that we deal with. Then in terms of economic and political context, what we are trying to do is put in mechanisms in terms of solutions that are not highly dependent on economic policies and political issues that would be prevalent within the wide sub-Saharan Africa. To the next slide, please. So what we are doing is that we're looking to build on our experience in implementation in the wider sub-Saharan Africa. What we've done so far is that we've created a platform that is cloud-based and interoperable with different health systems such as DHIS2, looking at issues around HRH systems that the government would have. We are also creating strong partnerships with governments because we deploy curricula that is approved by ministries of health, and we work with the governments to provide access to community health workers in an affordable manner. We are also looking to have different partnerships across the government space, looking at ministries of education, ministries of ICT, to be able to provide affordable education to our beneficiaries. And then also tailoring our community health worker training for different countries using a multilingual approach, providing supportive supervision to community health workers, and ensuring that we have a strong team in place to scale up the solution in different contexts. Next slide, please. So this structured approach looks at 5 key pillars. We have the preparation stage, where we do a quick feasibility study, establish a go-to-market approach, look at the technical capabilities that need to be in place, the stakeholders who would have to be in place. Then we also do look at the landscape in terms of who are the healthcare workers who we are going to train, and we create a business case for specific countries, which is contextualized to different settings. Once we've done this, we have an onboarding session for the learners, and we are able to provide support for the learners throughout the training process. As you look at our scalability approach in terms of how we are able to sustain the business, one of the things that we do is we have a business pipeline for different players within the different countries, negotiate different contracts, and again, provide learner support to ensure that we are able to provide the learners with everything that they would need to complete the topic. But over and above this, we're able to elicit feedback from different players to develop on the product and iterate on new features. Next slide. If you look at our progress to date, we've managed to raise approximately 3.5 USD through different players, through different partners, some in the pharmaceutical space, some in the development space, some from governments. We've reached a target number of 146,589 learners in 8 countries. And you can see there's a graph that shows you the projected learners versus target project learners. In totality, most countries have done exceptionally well and well within target. We are multilingual. You can see we have Amharic, we have Chichewa in Malawi, we have Swahili in Kenya, but across the board, more than half of the learners, close to 90,000, have chosen English as a preferred language. But this does not mean that the platform is not able to accommodate and assimilate many other languages. Quite naturally, you can see our female representation in terms of health workers is very strong, standing at close to 109,170, followed by our male compatriots who are at 37,419. And this is representative of how this would look across the wider sub-Saharan Africa. Next slide, please. So I will stop there, pause. I hope I've been within time, Meke, and I've managed the 5 minutes appropriately.
Thank you so much, Peter. That was an excellent and very succinct overview of some very exciting work. So Sintayu, over to you.
Thank you very much. So I will be speaking more about our experience in Ethiopia. So I'm audible enough, right?
Yes, go ahead. Thank you.
Yes.
Yeah, thank you so much. So I will speak about our experience in Ethiopia. So Amref Health Africa is one of the biggest international organization in Africa. So that is where I'm working. So we have about 35. We are present in more than 35 countries and in Africa, and we have also offices in 11 countries in Europe and North America. Who does mainly the business development. So one of the biggest offices is Ethiopia, where I'm working. So as you all know, the Covid-19 was first confirmed in Ethiopia on the 13th of March 2020. After that, as of yesterday, May 19, 2021, we have a total of 267 COVID cases in Ethiopia and over 4,000 deaths. And the total recovered patients, COVID patients, is about 222,000. The total, so far we have vaccinated over 1.5 million people in Ethiopia, by the way, with COVID vaccine, prioritizing most vulnerable population in Ethiopia. So the pandemic, as you all know, has a huge effect, especially on the health system. It has also affected the essential service utilization in Ethiopia. So when COVID comes, as you all know, the health system, especially the providers and the public, were also were not going to the facilities to seek health service. The provider were also afraid of contracting COVID, so there was also like absenteeism and so on. So overall, especially basic essential RMCH service utilization has been declining during when COVID outbreak was reported in Ethiopia. As you all know, we have a 3-tier health system. So the first one is primary health care system. So it is where health posts, I mean, the first health service delivery unit. Health post has health extension workers. So each health post has at least 2 health extension workers working, serving about 3,000 to 5,000 people in their catchment area. So I will mainly speak. I will mainly speak about the health post interventions that we have supported. So health extension workers, you know, we have they all are female and 10 grades, so they are salaried by government. So as I said, two health extension worker per health post. So this is just to give you an understanding of the health extension program in Ethiopia. So the health extension worker role in terms of like responding COVID-19 is it can be divided into three. The first one is prevention. You see, in Ethiopia, we have close to 40,000 health extension workers throughout this country, serving over 112 million people. So their main job is, in terms of COVID-19, is they give community education, engagement, they engage the community, they also sensitize the community in terms of basic prevention skills of COVID-19. They also organize kind of hand washing stations. They lead infection prevention. They also provide basic services at health post level. So they should be, they should protect themselves and the community from COVID by implementing infection prevention and control measures. In addition, they also detect COVID-19. They identify signs and symptoms, and they also conduct COVID-19. They can conduct COVID-19 testing or support sample collection, transportation, and so on. So they detect cases, they refer cases as well. And they also respond in terms of COVID. So combat misinformation, for example, when there was, when COVID comes, there was like so many misconceptions in the community. So they can help in terms of responding COVID-19, self-isolation, and so on, so that they can refer as well to the nearby health facilities. So they have a huge role in terms of responding COVID. In addition, they have also a huge role in terms of like providing or like maintaining essential services, essential health services. As I said before, there have been disruption of the health system. Attention was towards this COVID. So the basic maternal and child health services was disrupted. NC declined, antenatal care, postnatal care, skilled birth attendants, home delivery were also increasing during when COVID comes. So this is very critical, where mothers and children are dying because of lack of access to those basic services. So their role in terms of revitalizing or maintaining the basic services is demand creation. So they create awareness to the community that even the essentials, sometimes the community in Ethiopia were not aware about the presence of those basic services. They thought that everything stopped and now the focus is COVID-19. So they have to resensitize that. Provide basic essential services, for example, immunization, antenatal care services, they provide at health post level. So this was also interrupted. So basic essential services should have been started. Referral, for example, for skilled birth attendants, for cesarean section, for other higher level services, they have to refer to the higher clinic. So they should be aware about it. So during that time, even the health extension workers, you see in the rural areas, they don't have any basic information about COVID-19, about essential service, and so on. So there was like a confusion on the overall health system. So that is why we came up with a solution called the LEAP. So we adopted the LEAP platform that Peter has presented before to Ethiopian context. We developed the package into our own content with the Ministry of Health, with closely working with the Ministry of Health, and all the package that we developed has been led by the Ministry of Health and approved by the Ministry of Health. So we developed the basic training package for COVID-19 and for essential services as well. So the rationale, as I said before, is because the health extension workers are the backbone in Ethiopia. We cannot prevent COVID-19. We cannot achieve the maximum result without having them in terms of curbing COVID-19. So it's important to work to support health extension workers, capacitate them, and so on. And health extension workers, as I said before, are the key players of providing basic primary healthcare services, especially maternal, child, adolescent, and youth health services at health post level. So in collaboration with Ministry of Health, we fully we closely worked with the Ministry of Health and introduced this platform at the Ministry of Health, and it is owned by the Ministry of Health actually, and we use the server of the Ministry of Health because we don't want to introduce something that is not sustainable. So we closely work with them, and the Ministry of Health was willing to host this platform in their own server. And Ethio Telecom were also our key partners. They were also committed to provide free SMS services to train all the health extension workers. So this is a huge contribution from Ethio Telecom in collaboration with the Ministry of Health. And AMREF also gave a backup support in terms of like fully implementing this solution. So with this, we could be able to like provide trainings for health extension workers. So far, on COVID-19, 61% of the health extension workers and 71% of their supervisors have already completed the training. So we registered 37,740 health extension workers. And from this, we now 26,347 are taking the training, so they have started, and 23,000 completed the training. So this is a huge number of achievement. And their supervisors is also took the training. And on the RMSH essential services, because we have started this after this training, we started this recently. So far, we have provided close to 1,000 health extension worker, and 200 of their supervisors took the essential service training. It is right now they are also taking the training. So we also conducted a kind of like qualitative study, and we did we found some important feedbacks. The health extension worker clearly said that the training was timely. They said that it came when we need it. The information, especially COVID-19 information, to reach to the rural area, it takes time, as you know. So because of this solution, they immediately timely got the information, and they are aware what to do in terms of COVID-19 and in terms of maintaining essential services. So they said that it was like timely, appropriate, and very supportive in terms of preventing and coordinating COVID-19. Even sometimes they said like they didn't know how to manage a dead body. Even the community asked them how we can manage a dead body, but they were confused. So this information or the training was timely in terms of guiding the health extension worker and the community to respond to COVID-19. It also helped them to take the training from anywhere. So they just use any phone, smartphone or basic phone, and they take it from anywhere. And it's possible to repeat and revise. So if you miss something, you can go back and listen and took the training. So it helps them to remember. And when they go to household level, sometimes if they miss some information, they just took their mobile and refer, and it works 24/7. So daytime, usually, some of the health extension workers, they say it's like nighttime when they go to bed, they just start taking the training because they have time to take that. And so they can use 24/7 anytime, which is convenient for them. And it also avoid mass gathering. You see, to provide training, the people before, it used to, you have to bring all together, and it is a risk for COVID-19 transmission. So it avoids that. And they also advise if there is a possibility of arranging similar training for Kabare and religious leader, because these community actors are the key players in the community in terms of like awareness creation, prevention, and so on. So they advised us if we can also develop a similar training material for the community members. There was some challenges. You say this is mostly common challenges throughout Africa. Network problem. You see, in some area, in the very rural area, there is some mobile. Even you can get mobile network, so you cannot access in the training. And there was also some misunderstanding because the health extension worker, they didn't have any orientation at the beginning. So later we then design a kind of cascade training. So we train the regional people, the zonal people through Zoom, so that they can guide their health extension workers how to go through the training. So there was some confusion at the beginning, but later it helps us to redesign our intervention as well. So these are some of the pictures when the pre-test. So we conduct pre-test and post-test. This is, you see, when the health extension worker counsels the community with social distancing and COVID protocol and using LEAP platform. This is like conducting some kind of review meeting. So that is all. Thank you so much. Back to you.
Thank you, Peter. Thank you, Sentayo, for succinct presentation. It's very insightful, and thank you very much for that. We have received a couple of questions from the participants. So some are related to cost effectiveness, some with regard to motivation and about handovering to the government, and the other is about the completion rate. And also, in fact, you have mentioned about the challenge, Sentayo, about the network challenge. So we have a couple of questions. So I'll go ahead and ask the question as they're asked by the attendees. So the first one is, which relates to the cost effectiveness. It says, how do you know the cost effectiveness of the technology as compared to the traditional method? This is directed to Peter. And the other question is, how do you, on the same question, similar to that, how do you ensure the interest of learners on tracking, especially trainees that might not be happy due to paradigm and other related issues when you use technology? So one is about the cost effectiveness compared to other methods, and the second one is about motivation, because usually when it's a face-to-face, there are some motivations attached to it. So how is that affecting and how can you be maintaining the participants throughout using this technology?
Yeah, thank you. So I'll start with the cost effectiveness. If you look at the approach that we've used using technology, one of the things that we did is that we conducted a study with the Ministry of Health in Kenya. And what we established is that if you use the technological approach, it comes to approximately a third of the face-to-face costs. And this is because if you look at the aspect of bringing learners during the face-to-face sessions, you only bring them while you're onboarding them and when you're doing the pre-test and the post-test. Now, this aspect ties into the second question, which looks at motivation. When they come for the onboarding session, the allowances that the face-to-face learners get is also given to them during the face-to-face sessions. But what we also do over and above this to motivate the learners is that we ensure that they have supporting mechanisms in place. One of the supporting mechanisms is the group chat functionality. So regardless of where a learner is, they can reach out to a peer to ask a question and get an answer where they are not sure, or they can even reach out to the group or the supervisor. But what we have also realized is that there's a concept called learning buddies, which also works quite effectively. And a learning buddy is a learner who is more adept than other learners within the learning cohort and is quick to understand concepts, who is provided as a supporting mechanism to learners who may be slower to catch up with some of the concepts in order to ensure that no one is left behind within the learning cohort when training is continuing.
Thank you, Peter. The other question you may address along with this is with regard to the retention, because it ties into the motivation as well. So how is the completion rate?
So what we've seen in terms of the completion rate on average, it's around 60 to 70%, but this varies from country to country. And one of the things that we've done to try and create better retention mechanisms is using advocacy efforts together with the ministries of health to put in mechanisms that can be able to pay community health workers. A very good example is in Kenya, we have 47 counties, and we've started putting in advocacy efforts within 4 counties who have already passed health bills that pays community health workers. The other thing that we do is that we also provide the community health workers with up-to-date information within the different countries. One of the key issues that we established when we conducted a baseline in different countries is that the community health workers do not feel empowered when you go visit a particular household and someone has Google and they can basically get up-to-date information relative to or even better than what a community health worker would have. So we provide them with up-to-date information that enables them feel empowered to be a doctor within the community and a frontline health worker who is relevant and provides the right kind of information and appropriate messaging within the particular communities that they serve.
Thank you, Peter. Now we will also have received some questions to Sentayo. Maybe Micah, do you want to ask those questions or?
Sure. Yeah, thank you, Dr. Antoinette. And we've gotten some really excellent questions here. So maybe as a starting point, Sentayo, if you could talk a little bit about how the motivations or incentives for health extension workers to complete the LEAP program work, and also if you have any insights around the completion rates for particularly the essential health services training and why those were lower. So maybe we can start there.
Yeah, thank you very much. I think that is very important question. So in terms of the incentive, you see even in the qualitative finding, we also found that during the face-to-face training, they got per diem, allowance, and so on. But now they don't have that similar kind of incentive. So health extension workers, they raised the issue, even the supervisors, they raised the issue of incentive. And what we did was we discussed with the Ministry of Health to entertain this challenge. And then finally, we have decided to incentivize health extension workers who fully completed the training with mobile card. So there is small incentive for mobile card, like 50 birr. But in addition to that, later we also agreed with the Ministry of Health to provide certificates. So when they complete the training, we have agreed with the Ministry of Health to provide a certificate of training completion, which can help for their career development. So in addition to that, what we, especially in terms of like boosting the completion rate, especially at the beginning, there was some challenges. So we discussed with the regional health bureau peoples, focal person, health extension worker, focal person, Warada level and zonal level. We provided them a kind of orientation. We conducted review meetings so that they can closely follow the training of health extension workers. So it becomes like even the Ministry of Health, they were like following day to day. We generate report daily basis and we send that report to all personnel who are responsible to supervise the health extension worker. So during that time, you see, we have registered some number of health extension workers, for example, 37,000. Then each worada, they know their number of the number of health extension worker in their district and the number of health extension worker who took the training. So we can follow them, even we can follow them by names, who took the training, who is not taking the training. So this helped us to boost the training on COVID-19. But the essential service was started recently. So it was started about a month ago. So that is why the performance is low. So we are just moving toward this, providing this training. It is a new module that we recently developed, and the training is, by the way, translated into local language, the national language and local language. So we have Amharic version, we have Oromifa version, Tigrinya, Afarinya. So we have regional language. So the health extension worker can choose any language which help them understand better. And the module is fully developed with experts from Ministry of Health and AMREF Health Africa. So it is approved by the Ministry of Health. So yeah, over.
Thank you, Sintayo. So we have also a couple of questions that's related to handovering to the government and the government ownership of this solution, the LEAP solution. So how is that feasible and what can be done with that is the first question. The other thing is with regard to working with Ministry of Health and the Ethio Telecom, how was that possible, in unlocking that system and working with the Ministry of Health and the Ethiopian, the Ethio Telecom? How that process was able to be navigated through? So they wanted to know that.
I think in terms of like we, as I said, in terms of handing over, I mean, when we bring this solution to Ethiopia, the first thing we met is the minister. Actually, we started from the Minister of Health. So we don't want, as I said before, we don't want to introduce something that is not sustainable. So we discussed with the Minister of Health, higher level officials. We agreed that the solution is important or not. So then once we agreed, we then moved to the experts. We discussed with the IT team, we discussed with the policy and planning team, we discussed with the responsible unit health extension department, we discussed with RMCH department. So once we all agree that this solution is helpful, then we started to introduce. Then even the expert at the IT department, they are the one who manage. I mean, as I said, it is hosted in the Ministry of Health server. And we sometimes AMREF supports us in terms of equipment. For example, to improve the capacity of the server, we procure some equipment, IT equipment and so on. We provide technical backup, including our HEQ Peter has been supporting the team in the Ministry of Health. So that helped them to own the platform. So now they are the one who actually follow it. Our role is just to give supporters. In terms of unlocking, I think because it is our common interest. You see, I mean, we know that the health system backbone is health extension program in Ethiopia. We have more than 40,000 health extension workers who knock every household doors in terms of accessing health services. So without reaching this population, we cannot able to carve COVID-19 or other services. So we know that it is our backbone. So that is why all the government, the Ministry of Health and Ethio Telecom, they reach into consensus as well in terms of like responding COVID-19. So it is because a common interest for all of us. And that is why I think we came together and create this partnership. So I think it is a priority of the Ministry of Health, the priority of the government, and that is why, and we also support them. AMREF is doing, we understand the local context, we work closely with the Ministry of Health and other government offices, and we support them. We are not like we don't want to introduce some parallel or overlapping or duplicating interventions, but we want to strengthen the health system, and that is the ultimate objective, and that is why I think it is owned by the Ministry of Health and other stakeholders. Yeah, thank you.
Thank you, Sintayu. So we also have a couple of questions. Maybe I can start with Peter and then see also if you want to add, Sintayu. So there are a couple of questions about whether the LEAP platform is available or is being used for other health professionals in addition to the health extension workers and community health workers, and what the process is for accessing it and using it, and then also if it's being used and if it's being available and thought of also as a more general strategy for Ministry of Health professional development initiatives more broadly. So happy for either or both of you to answer that one. And Peter, I don't know if you want to start off.
Yes, thanks. So yes, the LEAP platform is being used for other health professionals. We've used it for an NCD program where we were training nurses, clinical officers on hypertension, diabetes, and cancer. And what we've done is that we've linked this training to service delivery to ensure that demand creation is provided from the community health worker space, which links to formal healthcare systems where nurses, clinical officers are based. And now this also links further to a higher cadre, such as doctors who would be medical officers and even professional doctors who now would manage oncology, hypertension, and diabetes, to close the loop from the community aspect to the formal healthcare system. Other instances where it's also been used to fight the pandemic and epidemics such as Covid19, where other cadres of health workers have been trained, and also cholera response in different countries. So yes, it's been used, and for anyone who would want to join an opportunity in terms of how to partner with us, we are totally available, both Sintayu's team in Ethiopia and our team on this side, to sit down, co-create and figure out a solution that will fit the context in which it's to be applied.
Thank you, Peter. Sintayu, do you want to add anything on that as well?
No, I think that is.
All right, great. So I think we have another question for you, Sintayu, as well, which is the decline of, or the decrease in utilization of essential services due to COVID-19, and how health extension workers have been able to integrate the focus and provision of basic services and also integrate COVID-19 response. So asking about sort of workload and being able to also participate in trainings like the LEAP program. What have you been seeing by being involved with that initiative?
Thank you again. The reason that we came up with the essential service is because we saw, when we see the data, you see we have DHIS2 data, and when we see especially on the first quarter or the first 6 months, around the first 6 months, the utilization of essential health services, as I said before, has been declining. It is, as I said, it is because of two reasons. One, the community are not interested to visit health facilities because, one, they don't know that the facility is providing those essential services, or they don't know that the essential service is already maintained. Two, they fear COVID-19, contracting of COVID-19. So this is the reason. And the provider as well, there was like a huge fear. So the provider, there was like absenteeism from facilities. Health extension workers, they are absent from their health posts and so on. So because of this, you see the utilization has been declining, and that is the reason that the Ministry of Health decided, so we have to resensitize the health system. Then we developed a training package, the module, and then we provided, we just launched it, the provision of the training through LEAP, so that the health extension workers will be aware. But basic information has been provided in the COVID training. So in the COVID training, the health extension workers were aware about to maintain essential services in their health post, maintaining the COVID-19 protocol. But now it gives the essential service training package, give details, and what should, I mean, there is some protocols for that we have changed following COVID-19. So we detail those protocols in family planning, antenatal care, and immunization, nutrition, adolescent health. So those detailed packages are developed and uploaded into the system. I think that is what you have asked. Let me know if you need.
Thank you very much, Sentayo. So we have 3 minutes before we conclude, but we have also other questions. I'll ask first Sentayo about the question that's asked is, what challenge has UMBRE faced in working with the Federal Ministry of Health?
You see, when we, I don't see, I mean, there is major challenge. So the challenges that we encountered when we come up with technology during setup, there was the capacity problem of on the server, so that we should procure something and so on. And there was in terms of equipment, but at the beginning, we have to discuss with each and every department, so that at first they should be aware about it and should accept about it. So there was consecutive dialogues at the beginning of this initiative, but otherwise there was no major challenges. The minister, actually the current Minister of Health, provided press release about it. Then it becomes it becomes one of the priority intervention in terms of responding COVID-19.
Thank you, Sentayo. The last question would be going to Peter, and it's about the skill. It says, assume your training platform is addressing knowledge gaps. Is it possible to use your platform for skills development?
Yes. One of the things about our platform is that you will notice that we do not only disseminate theoretical content. It's a blended training. Blended in the sense that any topic that we disseminate on behalf of the Ministry of Health has a practical aspect which is tied to the theoretical aspect. And now what happens here is that you have tutors who cater for the theoretical aspect, but you also have mentors who are mandated to supervise the practical aspects. So these two components come together to ensure that anyone who goes through a training program not only understands the theoretical aspect of any health program, but also carries out practical activities that will be able to demonstrate that they are able to carry out the theoretical knowledge in a practical manner in the communities that they serve, which are graded and scored in form of the certifications that they get at the end of each topic.
Thank you, Peter, for addressing the question. Bru has, before we conclude, Bru has an announcement to make. So Bru, over to you.
Thank you, Dr. Antana. So I want to thank you again for your interest in our course. And I am here to announce that we will send a course evaluation form that will be very valuable in improving our courses. So please try to complete the form that we'll be sharing shortly. And for your calculation of the recording of this live session and the whole course content, will also be sharing the link to the recordings of our live sessions. Thank you.
Thank you, Bru. Thank you very much, Peter and Santayo, for excellent presentations and also for addressing the questions, most of the questions that are raised by the participants. And I hope most of the participants have enjoyed, and from the discussions, we can say they are more interested to know about LEAP. And we want to thank you very much. We also want to thank all the participants for taking the time to be with us, and also asking excellent questions that triggers more thinking, and also triggering to see other direction as well. We want to thank you again for participating on this live session. We hope you to also complete the course, those of you who have not yet done that. And also, we want to say thank you very much for being with us today. And we end our live session with this. Any last word from Micah? We can, if she has anything to say to you, Micah.
All right, thank you so much, Dr. Antana. Thank you to the whole team. Thank you to the AMREF colleagues. And it has been a really, really exciting process. And we will also be going through the chats and the Q&A and make sure that if there are any outstanding questions that we weren't able to get to today, that we do address them. So yeah, wish you all a wonderful rest of the day. Feel free to reach out to us if you have any questions for completing the course. And thank you all again. It's been a great session. So have a great day, and hope to stay in touch.
Thank you all.
Thank you. Okay. Bye, everyone.
Bye.